of sleep disorder that we're going to go through is insomnia. Insomnia. Okay. It is inability to fall asleep or stay asleep. It is common in people of all ages. Insomnia can last for a night or two, but sometimes for weeks, months, or even years. People have problems falling asleep or staying asleep. Especially like, if you go to the hospital, patients don't get enough rest. The hospital is not a good place to get a good rest. Because you got everybody coming in. This minute, the respiratory therapist in there, man, you gotta take your breathing treatment. It's okay, I'm done with that. Oh yeah, we're gonna go walk around. This is physical therapy. Okay. This is nursing aid. Here's your food. So hospital is not a good place to get a good rest. So people at the hospital, patients don't sleep well unless they go home. Insomnia results in a non-refreshing and non-restorative sleep with impairment of daytime function. And that is true. If you don't sleep well, you're not going to function well during the waking hours. So we have types of insomnia. The first one is what they call the transient insomnia. Now, transient insomnia is caused by excitement or stress, when you have excitement or stress. For instance, let's say that you promise your children that you're going to take them to McDonald's on Friday, and this is just Monday. Well, when I get paid, I'll take you up to McDonald's. You think they will go to sleep? They won't go to sleep unless the Friday comes around and you take them to McDonald's. Okay, and then after that, they will start going to sleep. Okay, or maybe you go, well, I'm going to get married on the 25th of December. Okay. Well, you're going to stay up most of the time thinking about how to plan for that wedding. Okay. But once the wedding is done, then you start sleeping well again. Okay. So it's excitement or even a little bit of stress is what causes a transient insomnia. And the insomnia will go away after you have accomplished whatever that is causing it, causing you not to fall asleep. Any questions about that? And then we have short-term insomnia. Now, this is due to ongoing stress, like relational problems. Okay, you have problem with your spouse, okay? It's ongoing. You have problems trying to make your car payment. Anytime your car payment comes around, you worry yourself. How are you going to come up with that $550 a month? Okay? But what happens with the short-term insomnia is that after a while, you get accommodated to that. Okay? You get used to your husband abusing you. Okay? Or maybe you get used to making your car payment. So once you get used to that, then the insomnia will go away. Okay? Any questions about short-term insomnia? And then we have chronic insomnia. Okay, this one here is mainly caused by, a sleep disorder. Okay, like sleep apnea. Okay, where you don't sleep well at night. Okay, then during the day, is when you want to sleep. Okay. Now this one here can go on for a long period of time, and it's just treated. Okay, it doesn't go away. Okay, it's treated. Okay, for instance, if you're having sleep apnea, if you're talking about obstructive sleep apnea, you're going to wear your CPAP. That's one way that you're going to sleep well during the night, so that you can remain awake during the waking hours. If you have central sleep apnea, then you must, do things that will help you sleep well. Like avoid, if you're taking too much caffeine, you avoid that, or alcohol. In extreme cases, you can wear your BiPAP. BiPAP is good for central sleep apnea. Okay? So chronic insomnia, we can treat it, but it doesn't go away. Okay? So treatment for insomnia, addressing the cause. Okay? Abstain from a known cause. Whatever that you know that is causing you not to fall asleep or stay asleep, you try to avoid it. Okay? If it's your husband, well, go get a divorce. No, just kidding. Yeah, it's true. Why would you get married to fight all the time? It's not really worth it, And then good sleep hygiene. Okay. Go to bed early. You sleep well, you sleep longer. Be sure to make sure you're getting like 6 to 8 hours of sleep a day. Okay. If you're drinking too much coffee, try to lighten it up. Avoid alcohol, excessive alcohol before bedtime. You eat light food or snack before you go to sleep at night, because metabolism slows down during the night. Okay, so your food may not digest very fast. Okay, if you eat enough of it before sleep. So those things are called sleep hygiene. If you're the type that has to have their lights cut off before they go to bed, well, be sure to do that, so that you can sleep well. All right, so drugs may be used for short-term treatment of insomnia. If you have short-term treatment, short-term insomnia, drug may be used. Okay, you go to the doctor, you complain to the doctor that you're having difficulty falling asleep or staying asleep. They can give you sleeping medication. And we have those two there. Ambien is very common. Ambien, one thing good about drugs is that you got to know the generic name and also know the trade name, okay? Because on your board exam, they can call it either way. They can call it by the generic name or the trade name. So Ambien is zolpidem. It's a very common sleeping medication. Okay? And then there is Restorel. Restorel is diazepam. Those are two commonly used sleeping medication. But of course, one thing with somebody taking a sleep medication is that you get used to it. You become psychological dependent on it, that if you don't take it, you can fall asleep. So they can also turn around and cause insomnia. Okay? So that's why usually they like to prescribe it for a short period of time, not your entire life. At most 1 week. Okay, so that you can, discontinue using it and go back to normal. Any questions about insomnia? And then we have hypersomnia. Hypersomnia. Now, hypersomnia is excessive, constant, inappropriate, and undesirable sleepiness during the waking hours. Okay? Now, people that have hypersomnia will fall asleep in a minute. Okay? And they can be eating and fall asleep. Okay? They can be talking to you and fall asleep. Okay? So they have frequent involuntary naps. They have drowsiness. And then they have problems trying to concentrate because they did not have a good night's sleep. Things that can cause hypersomnia. Yeah. One of my students just passed the exam. All right, so things that can cause hypersomnia. The first one is sleep apnea. If you got sleep apnea, you don't sleep well during the night, you have a lot of apneas, and then during the day you want to sleep every minute that you get. So what is sleep apnea? The sleep apnea is when somebody quits breathing for 10 to 20 seconds during sleep. It can be caused by airway obstruction. In that instance, we're going to call it obstructive sleep apnea. Some upper airway structures will collapse during sleep and obstruct your airway. And then we have central sleep apnea. Now, that one is neurological in origin. Okay, it's not obstruction. Usually when the brain fails to tell the diaphragm to contract for you to breathe. Because that's basically the way we breathe. The way we breathe is, normal CO2 is 35 to 45. When your CO2 level rises above 45, the central nervous system recognizes that and then sends signal to the diaphragm to contract. So your diaphragm contracts, and then you breathe in some volume, and then you blow up the excess CO2, and then the CO2 is back to 45 or below 45. And then the central nervous system waits again until the CO2 rises above 45. So that's the way we breathe. But in this case here, the central nervous system is not sending that signal to the diaphragm to contract. And then you go apneic. So again, here is obstructive sleep apnea. Airway obstruction by upper airway structures. Your adenoid tissues, the adenoid tissues in your upper airways, your tonsils, your uvula, all those upper airway structures. When we go to sleep, they lose their tone. In other words, they are no longer as rigid. Okay, the upper airway structures lose their tone, become a little floppy, and then they collapse and obstruct your airway. So when you're trying to breathe in, there is no clear pathway for air to go into your lungs. Okay? And that's why you snore. Okay, it's obstruction. That's what causes snoring. The obstruction of the pathway for air to go in. So if somebody has obstructive sleep apnea, when they go apneic, okay, their oxygen will start to drop, okay, because they're not getting any air. So it gets to a point where their O2 level will fall, they'll wake up. Once they wake up, they make that ugly noise, like that. And then they sit up by the side of the bed and then they go, so they hyperventilate. There's always hyperventilation followed by that apnea episode, because now their oxygen is being down. So they're trying to catch up with their hypoxemia. Okay? So that is one of the distinguishing factors between obstructive apnea and central apnea. If you have obstructive apnea, when you have apnea and you get awoken by the low CO2, high CO2 or low oxygen, you're gonna have to have hypothermia to catch up for the hypoxemia. Okay, so that's what we mean here. There is absence of airflow because they are apneic, okay, and increased respiratory effort by the patient. Okay, so on the exam, they tell you describe a scenario like this where a patient had apnea and then their respiratory effort increased. After that, what would you diagnose? And then you are going to diagnose obstructive sleep apnea. Okay? Central sleep apnea, on the other hand, is neurological in origin. Okay, neurological in origin. And like I said now, it's all about the central nervous system sending that signal to the diaphragm to contract. That doesn't happen. Okay? Now, since that is not obstructive in nature, what happens is that when the patient gets awakened, I should say, right? Awakened by the low oxygen level, okay, they don't hyperventilate, okay, because it's not obstructive in nature. They don't hyperventilate, okay? All right, let's look at the treatment for each type of sleep apnea. For central sleep apnea, we want something that can wake up the central nervous system, get it into action, okay? So we give them respiratory stimulants, okay, respiratory stimulants. And we can do theophylline. That triggers the central nervous system and gets it to fire more often, so that signals will be sent to the diaphragm. Another name for theophylline is aminophylline. I think this is generic, and this is thread. The same thing. It's respiratory stimulants. They are also bronchodilators. If you remember that, we'll call them the xanthine bronchodilators. When babies are born prematurely, okay, meaning that their central nervous system did not develop well, they can develop apnea of prematurity. Sometimes they forget to breathe, okay? If any baby doesn't reach up to 35 weeks before birth, okay, their central nervous system will not develop well. They're gonna have apnea. So babies will give them IV caffeine. Caffeine, I think it's spelled that way. IV caffeine. So when you start your clinical rotation next semester and you go to the NICU, if you have a baby that is premature, more than likely you will see them on IV caffeine because it is a respiratory stimulant. Caffeine is a respiratory stimulant. And then another thing is that COPD patients drink a lot of coffee. They do because coffee is a bronchodilator. Coffee is a xanthine bronchodilator. Okay, it helps out their breathing a lot. Okay. Any questions? And then another thing that you can do for central sleep apnea is to look out for your sleep hygiene. Look and see whether there are things that you're doing, some habits that you have that may be causing you not to sleep well. Like that caffeine that we talked about, drinking too much coffee, or alcohol, or nicotine use, not having clean bedspread. When your bedspread is filthy, you're not going to sleep well. If you have roaches, you're not going to sleep well. They will crawl all over you. So things like that, okay? We gotta fix it. And then finally, we can have them use the BiPAP while they are sleeping. So remember that on your exam, okay? If they have central sleep apnea, what are you going to give to them? It's not CPAP. CPAP is for obstruction, okay? But if you want to put them on PAP therapy, you're going to do BiPAP. There is a difference between BiPAP and CPAP. Now, CPAP is one level of pressure. It's kind of like PEEP. CPAP is PEEP. We just call it CPAP because the patient is breathing spontaneously. But if you are on the ventilator, we call it PEEP. Okay, so PEEP is when the ventilator is giving that pressure. CPAP is when the patient is awake and breathing and getting that pressure. Okay, so CPAP is for obstruction. BiPAP is for central sleep apnea. Any questions about that? The only exception, sometimes we can use BiPAP on a COPD patient. Now, what does PEEP do? I know it's positive end expiratory pressure, the amount of pressure left in the lungs at the end of exhalation, but what does it accomplish?
Health of oxygenation and alveolar recruitment.
Yeah, very good. Alveolar recruitment, opening up some more lung units, and then also improving your oxygenation, right? Because if you look at PEEP or CPAP, if somebody's got atelectasis, their lung unit will be this way. They don't have enough surface area for gas to go into their blood. Because look, oxygen goes in through the process of diffusion. And one of the factors that affects the rate of diffusion is surface area. You gotta have surface area. So what we're gonna do then, we'll give you PEEP, we're gonna blow up this lung unit back this way, and then we have more surface area for gas diffusion. Your oxygenation improves. Now, if you put a COPD patient with high CO2 retention on CPAP, you're giving them PEEP because it's PEEP. PEEP improves oxygenation. So their oxygen level goes up. Is that good for a COPD patient? No, a COPD patient, you never want to give them too much oxygen. Never. That's why we say that their normal PaO2 is 50 to 65. If it's more than that, they can go to sleep on you. They go to sleep. And then they're going to start breathing on their hypoxic drive. What does that mean? I want you to understand this. Okay, so like I said before, CO2 is what causes us to breathe, CO2. When the level of CO2 rises above 45, we know to breathe. The central nervous system sends signal to the diaphragm to contract. And then we breathe, and then we blow up the excess CO2, and then we wait until the CO2 rises above 45 again. That's the normal way for us to breathe. But now, a COPD patient doesn't breathe that way. Let's say that this is compensated respiratory acidosis. Okay, that's normal blood gas for a COPD patient. Okay, their PaO2 50 to 65, so that's good for them. Okay, so what will happen then is if we give them that PEEP, that CPAP, and we raise this anywhere greater than 70, you never want their PaO2 to be greater than 70. If you raise it greater than 70, then what you're going to do now is that you knock out, because what they're doing here, instead of them breathing this way, they're breathing on hypoxic drive. When their PaO2 drops down, they know to breathe. They don't breathe because this is already too high. Okay, that's why it's called breathing on hypoxic drive. So if we give them too much oxygen then they go, well, yeah, we got enough oxygen, so we don't need to breathe. so their respiratory rate goes down. They quit breathing fast enough. When their respiratory rate goes down, then their CO2 will rise because they are no longer blowing off a lot of CO2. Two ways that you can blow off CO2, tidal volume and respiratory rate. So your respiratory rate goes down, your CO2 will go through the roof. So that's why if your patient has COPD with CO2 retention, you put them on BiPAP, because BiPAP is 2 levels of pressure. One for one for PEEP, the other one for ventilation and oxygenation. The IPAP is for ventilation. That's what gets rid of the CO2. And the EPAP is like the PEEP. So EPAP and the BiPAP, EPAP, CPAP, and PEEP are all the same. They are positive pressures. We call it EPAP. We call PEEP, EPAP and BiPAP. The same thing. The indication, the contraindication, the complications of EPAP and PEEP are the same. The same thing. We call it CPAP when a patient is breathing spontaneously. If you have somebody on a spontaneous mode on the ventilator and they're just breathing on their own, we call it CPAP. Whatever level of pressure that you set, we call it CPAP. If you have them on the ventilator and the ventilator is doing the work, we call it PEEP. So they are the same thing. So never you put a COPD patient with CO2 retention on CPAP, because that will cause their PaO2 to rise and then put them to sleep. Okay? So what we call that is oxygen-induced hypoventilation. Oxygen-induced hypoventilation. We're going to talk more about that when we start going over blood gases. Any questions about that? So particularly, I want you to recognize that on your exam. BiPAP is very good for central sleep apnea. Okay? CPAP is good for obstructive sleep apnea. Unless they have COPD with high CO2 retention, you put them on BiPAP. Okay? All right, so now let's go over here with obstructive. So the first thing there is CPAP. That is the most common treatment for obstructive sleep apnea. But the problem that we have with CPAP is patient compliance. Patients don't like to wait, and I really don't blame them. Has anyone here ever felt under pressure coming out from a CPAP machine? That's not normal. You know, it's not normal way for somebody to sleep. You have all this air coming to you. So people just don't like it. But it works. If a patient can remain compliant with it, wear it every night the way that they're supposed to wear it, their sleep apnea will be treated very well. Okay? So that's the only problem that we have with the CPAP. Okay? But now, there is a surgery that you can do to remove some of the offending tissues in your upper airway. For instance, they can remove your tonsil. They can remove your uvula. You know, uvula basically doesn't do anything inside the system. What the uvula does is to direct food down to the esophagus. Okay, that little thing hanging there. That's why it helps to direct food when you swallow directly to your esophagus. So you don't really need it. You can remove it, and then they can kind of trim your adenoid tissues. These are the tissues up there, your palate. Okay, so that surgery to remove or reduce the offending tissues is called the uvulopalatopharyngoplasty. Don't even try it. Uvulopalatopharyngoplasty. Okay? Now it just tells you what that surgery is all about. They're going to remove your uvula they're gonna, your tonsils, your palate, they're going to trim it. Okay, plastic means modifying it. That's what plastic means. Okay? But that doesn't, it's only about 50% success in treating obstructive sleep apnea. People can have this surgery and still have sleep apnea. Okay, now some people can have it and not have it anymore. Okay? So it's only about 50-50. It is a very painful surgery. I remember my brother had to do that. Very painful. If you do this surgery, in 1 week you have not eaten anything. You will be eating like jello, okay, for 1 week. Okay, because you can't swallow. Very painful. Okay? And then tracheotomy is not preferred, but it's the best treatment. The best treatment. This is where they're going to poke a hole in your neck. Nobody really wants that, because you're going to look different from the rest of us when we see a hole here. So, other than that, it is the best surgery to do. Then the patient, their airway will be here. They're breathing here, bypassing the upper airway. Okay, they won't have it anymore. Okay? Because the problem is in your upper airway. Any questions about that? The other type of sleep disorder is narcolepsy. Narcolepsy. It will also cause hypersomnia. Okay? They have a frequent involuntary naps. Okay? During the waking hours. It is neurological in origin. It's neurological in origin. Symptoms include excessive daytime sleepiness. Okay? Cataplexy, sudden loss of muscle strength. Okay? Cataplexy. Sleep paralysis. You go to sleep, and it's very difficult to wake up. Okay? It's almost like your eyes will be open, but you're there, you can't move your hand or your leg trying to get up. Okay? Hallucination just before falling asleep. They may be thinking how next week they're going to buy an airplane, but they work at Burger King. Is that possible? Dreaming about owning an airplane, but you work at Burger King. You might as well forget that. So they hallucinate a lot. It is not curable. Okay? Treatment is based on treating the symptoms. Okay? Medication to prevent excessive daytime sleepiness. Lifetime adjustment. Hey, what is that drug they call somebody's on speed? What is that? They say, I forget what they call it, but they say like he's on speed or something like that. That's medication that they take to stay awake. Okay? You probably know because the people that know about that are the people that smoke like marijuana. Those are the people that know that kind of drug, right? Ray is laughing. But there is something that if you take it, you never go to sleep during the day. Okay? All right. And then adjusting lifestyle, lifestyle adjustment, okay, will also help. And then we have parasomnia. That is another group of sleep disorder, parasomnia. This one here is abnormal movements or behaviors during sleep. Abnormal movement or behavior during sleep. The first one is night terror. Night terror. Now, this is very common in children. This is when a child will have like a frightening dream. They wake up, and go, mama, somebody's after me, and then they're shouting and crying, and you try to console them, they will shut up, okay, because they went through this horrifying dream, okay? And the child will not remember the dream, okay? It's more frightening for parents, really, than it is for the child. Okay? Night terror. And then we have sleepwalking, also called somnambulism. Okay? People get up from their bed and walk out to the street sleeping. Okay? Where you going? Well, how did that? You know, they actually what? There has been incidents where people actually get killed with sleepwalking. Get out from their bed, walk out from their house, and walk into the street, and they're sleeping. Now, if you become a polysomnographic technician, that's people that do their sleep study, and your patient gets up during the night when you're monitoring them, coming towards you, better run. And it happens. So what they do now, actually, when they do sleep study is, like, this is one room, the patient will be over there in the other compartment. So you can look at them even through the window. So if you see them coming towards you, go ahead and lock your door. Because they may actually think that somebody broke into their house. Right? They're coming after you. So people do that. Okay? So it is prevalent in children 5 to 12 years of age, and sometimes continues into the adulthood. Episode could last up to 10 minutes. That's a long time. Injuries and violent actions have been reported during sleepwalking. Okay? And then we have sleep talking. That's abnormal sleep disorder. Now, this is where somebody will go to sleep and they start talking. Okay? They start talking. I'm over here at Burger King. Man, please, would you give me 2 French fries and 1 hamburger and something to drink? And you're going, what? What is it? Thank you. And then you wake them up and say, what did you say? No, I didn't say anything. Well, I thought you were at McDonald's a few minutes ago, but no, I didn't say anything. So that happens a lot, okay? And this one here can occur in non-REM sleep as well as during sleep. Any questions? And then we have paroxysm. This is like grinding your teeth while you are sleeping. Grinding your teeth while you are sleeping. Well, you know, this is a sign of somebody just being mean. Somebody that grinds their teeth while sleeping is not somebody to mess with when they are awake. That's just a sign of being mean. Yeah, but it is a sleep disorder. Sometimes if you're having dental problems, doctors can ask you that. Do you grind your teeth when you are sleeping? Well, I know what. The doctor asked me that one time. I said, well, how am I supposed to know? I'm not supposed to know that. Okay, occurs more in children 10 to 20 years of age, especially when they have mental is like, it's a mental retardation or cerebral palsy. Okay? Mental retardation or cerebral palsy can occur in both stages of sleep, often precipitated by anxiety, stress, and dental disease. Any questions with parasomnia? There are more of these here, but these are the ones that they really want you to know. Okay. There's one called the restless leg syndrome. Okay. There's one called the work shift syndrome. So plenty of them. Okay. All right. So that's it for that. You know, today is going to be very, very short. Because when we do these two lectures, and I'm going to go ahead and edit.
Doctor, can you get the...
Oh, yeah.
Thank you.
Polysomnography. What that means is multiple studies during sleep. So you are doing different tests while the patient is sleeping. They need a lot of money. Because if you make more money, but the only thing is you're going to work night shift, and then you just watch others go to sleep while you stay awake. You know, that's the only thing wrong with that. Well, I don't know that anything else. You know? All right. Polysomnography measures how the activities of the body change during sleep. It is performed in the sleep lab. Sometimes it can be done at home too. Okay. But now the at-home study is more expensive than the lab. Okay, because the technician will have to come to your house and set up the equipment. And that usually yields the best result because you're sleeping in your own bed. Okay? Now, if you went to the lab, well, that's not your bed, you're going to feel different. You may not get a good sleep. Okay? And by the way, you don't know who is watching over you, whether they are rapists, you know? Now, I had a friend one time, this guy looks horrible. I'm sorry to say that, but he's kind of like ugly looking. And he was working, he went to the technician school at Paris, sleep tech, got his sleep tech certificate, and then got a job in the sleep lab. The very first night, the patient came there for him to do a sleep study on that patient. That was a woman. As soon as the woman walked in there and saw him, the woman ran away through the window. Yeah, because you don't know who he is. You don't know. So it is hard. It's really hard. Confirms the presence of sleep apnea and other sleep disorders. Polysomnographic result is used to diagnose or distinguish between obstructive and central sleep apnea. We can tell that goals of polysomnography identifies how often you stop breathing or have slow breathing during sleep. Okay. How many apneas do you have in 8 hours of sleep? Or how many times did you slow down breathing? Okay. In 8 hours. That's what we're monitoring. Okay. Identifies the extent of hypoxemia during sleep. That is true. Once you go apneic, your O2 saturation will begin to drop. I've seen patients that went all the way down to O2 saturation of 40%. 40%. Remember, O2 saturation, normal O2 saturation is 95% or greater. Okay? 90% or greater is acceptable, but 90% is not normal, is acceptable. So, but I've seen patients that went all the way down to 40%. Severe hypoxemia when they go up. So we want to monitor that, because if your oxygen is going way, way low, that will affect your cardiac function. That will affect your cardiac function. Okay? You have arrhythmias. Identifies a number of arousals due to sleep disturbance. That is true. They wake up each time they do apnea. They have hypoxemia, they quickly will get up, sit on their bed and try to catch up. Okay, how many times do they do that during 8 hours of sleep? Indications for polysomnography. When would you want to do polysomnography? Loud snoring or apnea during sleep. Usually, your bedside partner or your bed partner will tell you that. Okay? Your husband will say, well, honey, God, I can't go to sleep. You snore like crazy. Okay? But snoring does not always mean that you have obstructive sleep apnea. It can be your body position when you sleep. Okay? Now, I've seen people, when they go to bed, they actually, here's the head of the bed here, they are doing this way, but when they wake up, their head is on the other side. You know, people sleep crazy sometimes. Yeah, they change, right? Or maybe when they wake up, their head will be hanging down like that from the bed. So, all of this you have to monitor while you're going to sleep. Okay? But now, if you have abnormal position during sleep, that can cause you to snore. Okay, so snoring does not always mean that you have obstructive sleep apnea. Excessive sleeping during the daytime, that will be a reason to do sleep study. If you're sleeping during the day, then we are going to anticipate that maybe you are not sleeping enough during the night. Polycythemia of unknown etiology. Now, polycythemia is increasing red blood cells or hemoglobin or hematocrit. Okay? These three here are connected. Anytime your red blood cells go up, your hemoglobin will go up, your hematocrit will go up. If your red blood cells fall, your hemoglobin will fall, your hematocrit will fall. Okay, so an increase in any of these here would mean polycythemia. So, what happens then is if you're having sleep apnea, okay, you develop chronic hypoxemia. You develop chronic hypoxemia. You don't have enough oxygen. So, in order for more oxygen to be carried to the tissues, the body makes more hemoglobin. The body makes more hemoglobin to increase the oxygen carrying capacity. So anytime you see a patient that has polycythemia of unknown etiology, one of the things to suspect is sleep apnea or COPD. Okay, because COPD patients also have chronic hypoxemia. So their hemoglobin is always greater than 16. Okay? So if we see that, we know that you don't have COPD. I want to check it out. I want to see, I know why your hemoglobin is greater than 16. We do a sleep study. Pulmonary hypertension. Okay? All of a sudden, a patient develops pulmonary hypertension. Well, what's pulmonary hypertension? Like I told you before, we have 4 different blood pressures in our heart. Okay? So here is the right ventricle here, and here is the right atrium, Then the pulmonary artery comes out from here. Okay? Going to the lungs now. The pressure here, the normal pressure here, inside the pulmonary artery is 25/10. That's called the pulmonary blood pressure. This one here, from the left ventricle, this is the area. The pressure in here is called the systemic blood pressure, which is the 120/80. That's the one that everybody knows. Okay? We have other pressure. So we have pressure here. When the right ventricle is contracting, it's 25/0. And then we have here, when the left ventricle is contracting, it's 120/0. So altogether we have 4 different blood pressures inside the heart. So, but again, let me go back to this. The 25/10 is called the pulmonary blood pressure. So anytime the pressure goes above 25/10, that's called pulmonary hypertension. One of the things that can cause pulmonary hypertension is hypoxemia. Hypoxemia. So when you have sleep apnea, you have chronic hypoxemia. Hypoxemia will cause the diameter of the pulmonary artery to constrict. And once it constricts, the pressure there goes up. Oxygen is a vasodilator. If you have enough oxygen in your system, well, the vessels will remain open inside the lungs. If you don't have enough, they will tend to constrict. So that if my patient has pulmonary hypertension, I can say, well, yeah, let me check them out. Let me do a sleep study to see, whether they have, obstructive or central sleep apnea. Okay, because that can be causing that. Okay? Cardiac problems in the face of obesity and short neck. Now, obesity and short neck will predispose a patient to getting obstructive sleep apnea. Your neck is very short like this, very short, and then you're big. That is called the Pickwickian syndrome. Short neck and obesity. Pickwickian syndrome, that's what we call it. Okay? Now, if you go apneic during sleep, your heart rate goes up because your oxygen goes down. The heart is very, very sensitive to lack of oxygen. I don't know whether you have been told this. Anytime a patient comes to the hospital, not feeling well, there's something wrong about the heart, whether your heart rate is high or low or whatever. If you don't know what to give, you give oxygen. Oxygen is one of the most common drugs out there. Okay. Everybody gets oxygen. Maybe if you go to the hospital now and say, well, I'm here to visit my brother, they'll say, well, I don't care, here's oxygen. They give you oxygen whether you like it or not. Okay? So, Pickwickian syndrome, remember that, short neck and obesity will predispose a patient to getting obstructive sleep apnea. Okay? It is indicated for CPAP titration in patients with sleep-related brain disorders. Yeah, that is true. Well, you're having sleep disorder and you come to the doctor says, well, okay, we're going to try you on CPAP of 5 to see if that's going to get you to sleep well. Okay, well, they give you 5. Well, you're wearing 5, CPAP of 5, that's not working. The doctor said, well, okay, let's try 10. Well, that doesn't work. Well, in order to get the precise pressure that will help keep your airway open while you're sleeping, they can do sleep study. Okay, how do you wear the CPAP? Okay, with a level of pressure. Okay, now, what the technician would do is, if they start with 10, okay? You're wearing 10, you're sleeping, and then you're still snoring, then they will turn it up. Okay? They will try 12. Okay? They will get it to a point where the snoring goes away. If the snoring goes away, that means at that level of pressure is what you need to splint your airway. And so we can do that with sleep study. Indicated for patients that have insomnia and have not responded to pharmacological agents. And that is true. We know that chronic insomnia can be caused by sleep apnea. So we want to check that out. Indicated for patients with nocturnal seizures, people that have seizures at night. And seizures is when you don't have adequate oxygen going to your brain. Okay, you seize. Indicated for patients with parasomnia, people who are acting crazy during sleep. Okay, we want to check it out. Any questions about the indications for polysomnography? Yeah, sleep study. Like I said, it can be done at the lab or at home. Okay. Now, the home therapy is more expensive, but yields the best result because you will be sleeping in the environment that you are used to, okay, compared to going to the lab that you're not used to. Okay. But mainly, it is done more in the lab than it is done at home. Okay. Now, if the sleep study is scheduled in the lab, then the patient will arrive. Usually it's done at night, but it can be done during the day as well. Okay. Now, during the day, people really don't sleep very well. Get somebody to sleep during the day. Not really unless you're somebody that works the night shift. Okay. And then if you give them medication to try to get them to sleep, when you alter the result of the test. And so it's always good to do it at night, but it can be done during the day. Okay, but now, let's assume that the study is scheduled at night. The patient will arrive to the lab about 8:30 or 9 o'clock p.m. Okay? They get there, usually it's the technician and the patient. Okay? Once the patient gets there, you have to make them feel at home. You have to make them feel comfortable because they don't know who you are. That can also disrupt their sleep, but they don't know who you are. If you look mean, oh my God, they won't go to sleep. So what you're going to do is engage them in a conversation. How are you doing today? Where do you work? You're going to be very friendly. And then after that, you're going to give them a tour of the facility. Well, here's the restroom, here's my partner's office or whatever. Make them know the facility. Doing things like that will make the patient feel comfortable with you. Okay? But if they came into the lab and you said, well, here's the bed, go over there and lie down, I'll be with you in a minute. Well, that will not work. You're not going to get a good result. Okay? Okay, so now patients' heads may be shaped to facilitate the attachment of electroencephalographs. So that's on their head, on their scalp here. That helps to monitor the brain activity during sleep. Remember the REM sleep, the non-REM sleep is the deep sleep. Okay? So that's what we're monitoring. Okay. What level of the non-REM sleep is the patient in? Is it level 1, 2, or 3, or 4? Okay? They monitor that by brain waves when you're sleeping. Okay? The amplitude of the wave, like that, decreases the deeper you are into the non-REM sleep. So they monitor that. It draws on a screen. Okay, it draws. Okay, so now, if we need to, we can shape their hair a little bit so that the electrode will stick on there. And then you're gonna have a recording equipment. It's kind of just like a computer. And everything that you're gonna hook up to the patient will show on the screen. Their O2 saturation, their EKG, their abdominal movement, everything will show on the screen. So you always have screen on the side where you are. Okay? So now these are the things that we're going to attach to the patient. So that's why we call it multiple tests during sleep, polysomnography, multiple tests during sleep. We're going to hook up oximeter to the patient. The oximeter measures the patient's oxygen saturation so that when they have apnea, you'll be able to record, okay, the extent or the magnitude of the hypoxemia. Did their O2 sat go all the way down to 60? Or did it go down to 40%? Or did it fall to 90%? The SAP monitor will tell you that. Okay? And then they hook the patient to electromyogram. That's for muscle movement. How you're moving your leg and stuff. Electromyogram. Okay? When you move your muscle during sleep, it records on the monitor. Usually put it here. Okay, all down here. And then they will also hook you up to electroencephalogram. Electroencephalogram, sorry. Electroencephalogram. That's on your eyelid. You put it right here. So what that does is to monitor the REM sleep, because your eyeballs are moving on the inside when you're in REM sleep. That's what the electroencephalogram does. They will hook you up to EKG equipment, so we can monitor your cardiac rhythm. So now, when you have apnea, your oxygen saturation goes down, and then that affects your heart. Well, what kind of rhythm are you getting? Are you getting sinus tachycardia? Are you getting atrial fibrillation or atrial flutter? What kind of arrhythmias are you getting as a result of your apnea? That can help us to assess your cardiac function, okay? Or the extent of the effect of hypoxemia on your heart. And then they have the wait a minute. I thought I did that. Okay, electroencephalogram. Okay, that goes on your head, on your scalp. Okay, to monitor the level of sleep that you're in. Okay, monitoring the brain activity. Okay. And then they will put what they call their inductive plethysmograph. It's like a belt. Belt, they put it around the stomach like that. So what happens is, if you're breathing, you move the belt and it shows up on the screen like that. Okay, now when you have apnea and you wake up and you have obstructive sleep apnea, you're going to have rapid breathing, hyperventilation, and it kind of goes like that. Because you're going to go, to try to catch up with the hypoxemia. Okay, so that's what that does, okay? But now, if you have central sleep apnea, when you wake up, this is still gonna be the same. Okay, you don't have any increase in respiratory effort. If it is central sleep apnea. Okay? Any questions about that? They can hook you up to capnography. Capnography measures CO2. It is a CO2 detector. Well, we breathe in mostly oxygen, and then we exhale our carbon dioxide. When you go apneic, it means that you're not taking a breath. Therefore, you're not going to exhale any CO2. So that lets the technician know that you are now undergoing apnea because no more CO2 is being sensed. Okay, so that's what the capnography does. And then they can put like a miniature microphone by your neck here. Okay. That's for snoring, to hear when you're snoring. The microphone will pick it up. Okay? And then, of course, they have the monitor, what the technician say. Everything that they hook up to you will show up on the screen. Okay? So what are we measuring then during the night? We want to measure how many times that you went apneic. Okay? And how many times that you have slow breathing. Now, slow breathing, let me rephrase that. Hypopnea is reduced tidal volume or flow during sleep. Reduction in tidal volume or flow into your lungs during sleep. That's what's called hypopnea. The other one, you have shallow breathing as a result of the obstruction. Okay? And then apnea is when you completely quit breathing. So we're measuring to see how many apneas will you have and how many hypopneas will you have in 8 hours of sleep. And then you want to monitor to see whether the patient is going through the stages of sleep. Because if they're not, then that's sleeper disorder as well. It's supposed to be that once you fall asleep, you go into a deep sleep, which is non-REM sleep, and then you go through the 4 stages of the non-REM sleep, and then you revert back to a REM sleep. Now you stay in REM sleep for a while, then you go back to deep sleep. That's the way it's supposed to work. So if you're not going into both phases of sleep, then you have sleep disorder. Okay, so we're monitoring that. Okay? And then we're also monitoring how long you're spending in each phase of sleep. Okay? It's supposed to be that 75% of the sleeping time will be spent in the non-REM sleep. And then 25% will be spent in the REM sleep. And so if you come to REM sleep and you stay there forever trying to dream, well, that's a problem. Okay? That will be part of your problem there. Or maybe you go into deep sleep, you're only staying there for 25% of the sleeping time. Well, that's a problem too. You will never get a good rest. The time you get a good rest is during the non-REM sleep, the deep sleep. That's when you actually rest your body and your mind. So again, apnea time, okay. Anytime the patient goes apneic, it has to be greater than 10 seconds. If it's not, then we don't really count it as an apnea episode. Okay? So any apnea that the patient had that was greater than 10 seconds will count. Presence of hypopnea. Okay, how many times did their tidal volume decrease or their inspiratory flow decrease during sleep? Okay. So we're going to count all these up. The end in the morning. Okay. How many apnea, how many hypopnea, and then we're going to work it out. So we're trying to measure what we call the apnea-hypopnea index. Apnea-hypopnea index, AHI, okay? So they take the number of apnea and hypopnea per hour of sleep is used to measure the severity of the sleep disorder, okay? How many apneas and hypopnea did you have in 1 hour of sleep, okay? So apnea time must result in a 4% decrease in oxygen saturation to count. Okay, now let's say that your normal oxygenation when you're not having apnea is reading like 96%. Okay, now you go apneic while you're sleeping. The technician will have to look at the sub monitor. If your O2 saturation drops below 92% now, then that will count. Okay? But if not, it doesn't really count. Okay? So now, we add up the apneas and the hypopneas. Okay? And then we're going to divide it by the number of hours of sleep. Okay, if you slept for 8 hours, we'll count the number of apneas and hypopneas during that 8 hours of sleep. We're going to divide it by 8 hours. And then we'll classify it this way. If you come up with 5 to 15, okay, we'll call that mild sleep disorder. If it is 15 to 30, we'll call it moderate sleep disorder. If it's greater than 30, we'll call it severe. Okay, so apnea-hypopnea index, greater than 30 will be severe sleep disorder. 15 to 30 will be moderate, and 5 to 15 is mild. You don't want to forget that. It usually shows up on the test a lot. Any questions? Now, this is what the monitor will look like. Okay? Here's the EKG thing there. Here's the respiratory air for deep out. Here's the O2 saturation. Here's the microphone. Here's the, this one here looks like EKG too. Okay. No, I think it's brainwave. Okay. That one. And this one, I don't know if I remember what that is. Yeah, but brainwave, yeah, so the technician is able to monitor all of this. When you do your sleep lab rotation, you're going to see that. Okay? Any questions about what we went over? Okay, other issues about sleep study. It is expensive and not available at every hospital. Not every hospital has a sleep lab, and it's very, very expensive. Now, sometimes your insurance company has to approve it before you can get it done. Sleeping in a bed that is not yours may affect results, and that is true. Okay? It will be all strained in the lab for you. Okay? You may not sleep the way that you might sleep when you are at home. Tests may be repeated. Okay? If you do the test and the doctor is not satisfied with the test, you can do it over. Okay? Especially with titration of CPAP. So the first time the patient had titration done, the technician did like a pressure of 10, and then after that the patient is still snoring. Basically, the doctor can recommend that the patient go back to the lab to have it redone. Okay? Study can be done at home, like I said before. Yeah, you can do it at home, not a special request. The at-home study comes out better because you're sleeping in your own bed, but it's more expensive because the technician has to carry everything with them, and transport it to your home. CPAP may be one during the study so that the pressure titration could be met, and that is true, okay? You let them wear the CPAP so that you can titrate the level of pressure that will remove the snoring, okay? That's how we know. If the snoring is gone, no longer snoring, then you got the right amount of pressure. Any questions? Can you believe that?